Welcome to the deep dive. Our goal, as always, is to sharpen your knowledge, focus on those critical details, and really give you that edge. Today, we're diving straight into something absolutely vital for aspiring surgeons, especially all of you prepping hard for the MRCS, the hip joint examination. We're working from a very practical clinician's guide here, focused squarely on application. So, the mission is clear: unpack the essential steps, the really key observations, and those specific special tests for a thorough hip exam, making sure every detail counts for your success. Okay, let's get right into it for you.
Exactly. And what's really interesting here, I think, is how this systematic approach, it's not just about, ticking off boxes. It's about building a kind of diagnostic map in your head. Every little thing, from how someone walks in to maybe a tiny pelvic tilt you spot, it becomes a signpost. It really guides your next steps, stops you going down blind alleys, and lets you sort of see the clinical story unfold.
That's exactly the mindset. So let's start with that foundational approach. The one we use for pretty much any joint exam, but applied specifically to the hip. The guide stresses starting with the patient standing, hip fully exposed, and critically important, always ask about pain before you start.
Absolutely. Don't skip that.
No, it really shapes everything that follows. So the hip, classic ball and socket joint, follows that pattern we all know. Look, feel, move, and then the special test.
That framework, look, feel, move, special tests, it's
Yeah.
just so vital, especially under exam pressure. It keeps you consistent, keeps you thorough. It stops you missing things and helps build that complete clinical picture efficiently. It's the difference between chaos and strategy, really.
Right. Strategy is key. So let's zoom in on the look phase first. This part is honestly incredibly powerful. You can gather so much information before you even lay a hand on the patient. The guide suggests starting general. Just look around the bed. Are there walking aids, crutches, a cane, maybe shoe raises?
Simple things, yeah.
Simple things, but they immediately tell you something about their mobility potential issues.
Definitely. In an exam, those first, say, 30 seconds of just observing, looking for aids, seeing if the patient looks generally well or if they're clearly in pain, that can be incredibly efficient. It points you towards areas you'll need to focus on later, even before you start palpating.
Then you're really watching their gait as they walk, if possible. You're specifically looking for, say, an antalgic gait, that pattern where they try to spend less time on the painful leg.
Limping, basically.
Yeah, avoiding the pain, or maybe a Trendelenburg gait, which we'll definitely come back to. And also, look at their posture standing still. Is their leg length inequality? And this is a key distinction. Is it true inequality, meaning one leg's actually shorter, or is it apparent inequality, maybe caused by a hip deformity like FFD, that just makes it look shorter? Getting that difference early is vital.
And connecting that to the bigger picture. These first visual clues are so powerful because they start guiding your focused assessment straight away. Knowing if you're likely dealing with true or apparent leg length discrepancy, for instance, it totally changes how you approach the move phase and the special tests later on. Saves time, improves accuracy.
Okay, so from those general observations, we get more specific. Inspecting the hip area itself. You're looking closely for any swelling, obvious muscle wasting.
Like the quads, they can go quite quickly with hip problems.
Exactly. Quadriceps wasting is a big one. Or signs of inflammation, redness, warmth, though you'll feel for warmth later. And don't forget to look for sinus tracts, those little openings that might suggest a deeper infection.
And it's important to do this systematically, isn't it? Anterior, then lateral, then posterior review.
Yes, absolutely. That 360-degree approach.
That comprehensive sweep, just make sure you don't miss something subtle but important. Every little observation adds a piece to the puzzle, which is exactly what examiners want to see, that you're building that diagnostic picture.
So, drilling down, anterior inspection. You're scanning for scars from previous surgery, that quad wasting we mentioned, any sinuses, any visible fixed flexion deformity, FFD, or rotational deformities. And a really key step here. Put your hands on both ASIS, the anterior superior iliac spines. Are they level? This immediately tells you about pelvic tilt.
Right, which could be the main problem or just compensation.
Precisely. Then move laterally, still looking for scars, muscle wasting, maybe the glutes this time sinuses, and also check for an exaggerated lumbar lordosis, that inward curve of the lower back.
Because that can sometimes compensate for a hip flexion deformity, right?
Exactly. The body tries to hide the FFD. And then finally, posteriorly, checking again for scars, wasting of the glutes or hamstrings, maybe any unusual tufts of hair over the spine, scoliosis, and again, sinuses. It's like layering the information.
That systematic anterior, lateral, posterior view, it's not just a checklist. It forces you to consider every angle, make sure no small detail gets missed. You're building that complete visual story of the hip.
Okay, great. Let's move on to the feel phase, now palpation. And the guide hammers this home again. Always ask about pain before you touch them. Seriously, it's non-negotiable.
Crucial first step in feel.
First off, gently check the temperature over the joint using the back of your hand. Is it warmer than the surrounding skin? That suggests inflammation. Then you'll carefully palpate for any local tenderness, directly over the joint itself and also the soft tissues around it. Follow where the pain might be coming from.
And knowing your anatomy here is just essential.
Totally. Where exactly is the hip joint? It's posterior to the femoral artery, right at the mid-inguinal point.
Which is halfway between the azos and the pubic symphysis.
That's the spot. You also need to palpate key bony landmarks. Find the ischial tuberosity, the sick bone, feel the greater trochanter on the outside of the hip, and trace the tendon of adductor longus in the inner thigh. Any tenderness there.
And don't forget the inguinal lymph nodes.
Right, a quick check for those too could indicate infection or inflammation nearby.
This raises a really important point for anyone taking the MRCS. Why is knowing these landmarks, this precise anatomical localization, so critical during palpation?
Good question. What's your take?
Well, it's because palpation isn't just about poking around for pain. It's about confirming what you saw, or maybe didn't see, and pinpointing the exact source of tenderness. Knowing those landmarks means your assessment is accurate. It helps you narrow down your differential diagnosis and think about what might need to be done next. It's moving from just looking to precisely identifying.
Great way to put it. Okay, now let's get into the move section.
Right.
Range of motion. But first, even before the specific movements, check for joint crepitus. How do we do that? Place one hand gently over the hip joint itself.
Yeah, just resting it there.
And then slowly, gently roll the femur laterally and medially. Feel for any clicking, grinding, creaking sensations under your hand.
That could be an immediate clue about cartilage damage or arthritis.
Exactly. Now, on to a really fundamental test for the hip, Thomas's test. This is the one specifically designed to pick up a fixed flexion deformity, an FFD. So how does this test actually reveal an FFD? What's the mechanism?
Okay, so the patient is lying flat on their back supine.
Right.
And the absolute key here, as the guide says, is you need to flatten their lumbar lordosis. Put your hand flat under their lower back, between them and the couch.
Okay, I've got my hand there.
Then you flex the patient's good hip. Ask them to pull their knee right up towards their chest and hold it there. This should press their lower back firmly down onto your hand, flattening that curve.
So the lumbar spine is flat, no sheeting with the back arch.
Exactly. Now, watch the leg. You're actually testing the opposite one, the potentially bad hip. Ideally, it should stay completely flat on the couch.
But if it lifts off?
If that leg lifts up off the couch, the angle it makes with the couch is the fixed flexion deformity. It shows you how much flexion is stuck in that hip.
Because it can't fully extend once the pelvic tilt and lumbar lordosis are taken out of the equation?
Precisely. The test isolates the true hip joint limitation. The guide mentions normal hip flexion is about 0 to 120 degrees. Thomas's test basically assesses the zero end of that extension range. By flattening the back, you remove that compensatory arch, and you unmask the real FFD the patient might otherwise hide. It's clever.
Very clever and essential to perform correctly.
Yeah.
Okay, moving on to other specific movements. Abduction and adduction. What's the key here?
Immobilizing the pelvis. You absolutely have to stop the pelvis from tilting along with the leg movement.
How do you do that?
Place your hand firmly on the ACIS, the opposite side, the contralateral side. Hold it down.
Okay, pelvis fixed.
Now, you can assess true hip abduction, moving the leg outwards, normally to about 45 degrees, and then adduction, moving it inwards across the body, normally to about 25 degrees.
And while you're doing that?
Feel the range, note the degrees, and again, listen or feel for any crepitus.
Right. Then rotation. First, internal and external rotation with the leg straight in extension. You watch the kneecap, the patella as you roll the leg in and out. Should be about a 90-degree total arc. Again, note the range and any crepitus.
Yeah.
And then you test rotation with the hip flexed. So flex the hip and knee up to 90 degrees.
Like they're sitting in a chair but lying down.
Exactly. And from that position, assess internal rotation turning the foot outwards, which should be about 30 degrees, and external rotation turning the foot inwards, which should be about 45 degrees.
And still noting crepitus.
Still noting crepitus, definitely. Different movements can stress different parts of the joint.
And just to reemphasize, fixing that pelvis for abduction is so important because otherwise you're just measuring pelvic tilt, not true hip motion. That's a common mistake to make in an exam setting.
And noting the specific degrees, like the guide points out, gives you objective data. It's not just a bit limited, it's abduction limited to 20 degrees. That's crucial for diagnosis and tracking changes. Shows you know the norms. Excellent points. Okay, we've looked, felt, moved. Now we're at the final stage, special tests. And for the hip, the big one is Trendelenburg's test. How do we set this up? You face the patient, who needs to be standing for this one.
Right.
Have them lightly rest their hands on your shoulders, just for balance. You don't want them holding on tight, just steadying themselves.
Yeah, not supporting their weight.
No. And you place your hands on their ACEs again, so you can feel for any pelvic tilt really accurately. Then you ask them first to stand on their good leg, lifting the other foot off the ground by bending the knee to about 90 degrees. Watch what happens to the pelvis.
Okay.
Then have them switch legs and stand on the potentially bad leg, lifting the good leg. Again, watch the pelvis closely. This test tells us something very specific, doesn't it? What are we really looking at here?
We're looking directly at the function of the hip abductor muscles on the side they're standing on, primarily the gluteus medius and minimus. Normally, when you stand on one leg, those glute muscles on the standing side contract really strongly. What that should do is tilt the pelvis on the opposite side, the non-weight-bearing side, slightly upwards,
Swap upwards.
to lift that side of the pelvis so the swinging leg can clear the ground when you walk. It's essential for a normal gait.
Okay, so that's normal. What's a positive sign?
A positive Trendelenburg sign is when those glute muscles on the standing side are weak or not working properly. Maybe nerve damage like an L5 issue, muscle wasting, or maybe the hip joint itself is unstable, like after some surgeries or in dysplasia. If those muscles fail, the opposite side of the pelvis, instead of tilting up, actually drops downwards.
Okay.
And to stop themselves from falling over, the patient will often lean their upper body towards the side they are standing on, the side with the weak muscles.
So you see the pelvic drop on the non-standing side, and maybe a trunk lean towards the standing side.
Exactly. That combination is the classic positive sign. It tells you immediately there's a problem with the hip abductor mechanism on the standing side. It's a really powerful clinical sign.
Fantastic explanation. And that really wraps up our detailed look at the hip joint examination. We've walked through the whole systematic approach. Look, feel, move, and the crucial special tests like Thomas's and Trendelenburg's. All those structured steps are just so essential for the MRCS, building that picture piece by piece.
And remember, just knowing the steps isn't quite enough. Mastery really comes from practice, practice, practice. Doing it repeatedly, deliberately, and really understanding the why behind each step. What pathology does this finding suggest? That clinical reasoning is key.
Absolutely. Knowledge is definitely most valuable when you can actually apply it effectively. So here's something to think about as you continue studying. Consider how truly understanding that difference between apparent and true leg length discrepancy, something we spot right back in the look phase, how that distinction could completely shift your entire diagnostic pathway for a patient who comes in with hip pain. It's not just a minor detail. Getting that right up front can fundamentally change your approach and management plan. It's one of those aha moments. Thank you for joining us for this deep dive today. Keep practicing, keep learning, and we'll be back soon with more insights to help you succeed.